Thank you, sir, for the kind words. A very good afternoon to all of you. It is a pleasure meeting you again since past so many years. After kidney comes the skin, so it is like Chandni Chowk to China. So let me take you through this journey because, and as you can read from the title of the topic, skin and soft tissue catastrophe are rarely encountered in our critical care practice. But it is important to diagnose and treat early because otherwise we end up losing the patient. So that's the importance of this condition. So in this lecture, we will try to focus on these few aspects of skin and soft tissue conditions that are catastrophic in the ICU, on the diagnosis, on the risk factors, management and prognostication, complications, and some of the unique aspects of the care which are pertinent to those conditions as well as during the treatment. Let me take you through the first case. A 20-year-old male laborer, a survivor of building collapse, rescued by the trauma team after one day, and he had fractured both bones of the lower limb with extensive soft tissue injury. He was dehydrated, hypotensive, had a large swelling of the limbs. There was limited trunk forward flexion and extension associated with limitations of hip flexion. The sensations and reflexes were, however, normal. The creatine kinase was very high, so was potassium, and there was hypocalcemia. The urine was extremely dark. In fact, it was brown-red in color. So what is the diagnosis? Yeah, so Crush syndrome leading to rhabdomyolysis. So now this is one of the conditions, as you know, which occurs because of muscle tissue breakdown. The skeletal muscle tissue breakdown occurs usually following trauma, and there is release of those intracellular contents into the circulation, and because muscle is the source of creatine kinase, the creatine kinase levels goes up, and so does myoglobin. And when this myoglobin comes into the urine, it produces the typical color of the urine. And besides that, this myoglobin can also break down into certain toxic compounds which can lead to acute tubular necrosis and renal failure. But the important point is that clinically significant rhabdomyolysis is often difficult to diagnose. So many of such patients are not taken to the ICU despite rhabdomyolysis process continues unabated and gets controlled also while the patient is in the ward or in the emergency department. And more so because it is also characterized poorly biochemically initially, during the initial stages. So, primarily, although the causes are, physical causes are important, but there are a good number of non-physical causes. The first, the top of the list, of course, of them is the drugs and the toxins, followed by certain infections, electrolyte imbalances, autoimmune disorders, and genetic defects. Why it is important is for the fact that sometimes in a patient, although the patient may have come with some physical causes, there might be some background of non-physical causes, and these multiple causes interact to produce this syndrome. So if those conditions are missed and not corrected, then that eventually leads to deleterious effects. So it is important to rule out all the non-physical causes too, in spite of identifying the exact pertinent cause. So in that drug and toxin list, you find the top of the list are formed by the addictive agents, alcohol, amphetamines, cocaine, etc., followed by antihistaminics, antiemetics, certain corticosteroids, antipsychotics, phenothiazines, etc. The list is not complete and not in order, it is alphabetical. So there are certain common drugs as well which can produce this condition uncommonly. In an ICU setting, you have to realize that certain figures which have come up, that it occurs in a very large number of patients with traumatic injuries. So whenever the traumatic injury patients are being evaluated, so this is probably one condition which needs to be ruled out. And there are causes of 5 to 25% cases of acute renal failure. 28% of the causes of post-traumatic ARF require dialysis. And rhabdomyolysis induced renal failure has a mortality of approximately 20%, which is pretty high. At least 1 out of 5 patients are dying. And this is increased in patients who develop MODS. So in this setting of these figures may give some hint that you have to treat these patients early in the best possible way. As you can see in the pathophysiology, it is the excessive, prolonged or repetitive exercise which overstretch the sarcoplasmic reticulum, and there is increase in the calcium leakage into the muscle cells, which activates the sarcolemma degrading enzymes, leading to an increase in the permeability and the release of proteins in the blood, ultimately leading to renal failure, DIC, etc., etc. Now, in the kidneys, it's particularly noted because its effect on the kidneys is because of all three factors. One, because of third spacing, because of the volume depletion, where it produces the proximal tubular lesion, reducing the GFR. Secondly, by myoglobinuria, producing casts, causing tubular obstruction, again reducing the GFR. And third and important cause also is the release of certain endotoxin, which is mediated by those intracellular contents of the muscle which have come into the blood and which produce afferent and efferent arteriolar vasoconstriction. So all of this culminate to produce a fall in the GFR, leading to acute renal failure. So the presenting symptoms in these patients depend on the primary disease process or the primary condition which has resulted in this condition. Superimposed symptoms of renal failure or muscle injury are often present. The classic triad of myalgia, weakness and T-colored urine is found in a very small percentage of patients, less than 1/4 of the patients. In case of children, other than that, they often have viral prodromes. So children who are coming below 8 years of age, the viral prodromes should also lead to the suspect because there the muscle mass is much less. So they are prone to undergo lysis at a much lower level of anticipated stress. The systemic manifestations are non-specific, but the specific features of AKI or DIC and arrhythmias and all, they will all be in the advanced cases. So the gold standard diagnosis is the determination of plasma CK. A concentration of 5 times the upper limit is commonly used as the reference range. And you have to remember that you can also look for the myoglobin, but it has a very short half-life. So we will tend to miss out those cases if we depend on myoglobin in the serum alone. The CK don't have that limitation. And a greater than 5,000 units per liter of CK concentration is closely related to the development of kidney damage. So that damage may be progressive and that had to be treated early. And in patients who are having that T-color type of urine, if you do an urine dipstick, you get positivity for erythrocyte. Now, when to suspect rhabdomyolysis? Of course, when there are risk factors, which includes the whole lot of these conditions. If there are certain indirect clues like the presence of muscle injury with an unexpected rise in the serum phosphate or AST, because the source of AST is also the muscle. If the neuromuscular examination of the extremities will give some clues like presence of normal sensation and normal reflexes in the state of increasing weakness. And in the non-verbalizing patients, of course, the color, pulse, sensation and muscle power are all informative to clinch into a confirmatory diagnosis. If you look into the complications, you will find that it can produce a host of complications if not treated early. And this can vary from acute kidney injury, which with the requirement of hemodialysis, to compartment syndrome necessitating fasciotomy, hypovolemia leading correction with fluids. Hypocalcemia occurs early, which is often followed by hypercalcemia in the late stage, so it does not require correction. But hyperphosphatemia is again one condition which will require or necessitate diuresis, and if not controlled, then hemodialysis. Hyperkalemia will lead to the set of pattern, and of course the DIC, which is again a late complication. So the principles of management is one, to prevent further muscle damage, and that to interrupt the immobilization of any kind, which is reducing the blood flow to that particular area. And in case of compartment syndrome, you don't have to delay and you have to go for quick fasciotomy. And the second principle of management is prevention and treatment of ARF. Initially, of course, through early and vigorous fluid administration, and if it goes into the RRT stage, you have to start RRT early. So the aims of this early vigorous fluid administration in rhabdomyolysis would be to rapid alleviation of the shock by depletion or a repletion of hypovolemia and correction of the acid-base balance and electrolyte status, alkalinization of urine to protect the kidneys against the nephrotoxic effects of myoglobinuria and hyperphosphuria. Although there are certain proponents against this too, protection of the muscle integrity and reversion of the inappropriate arteriolar vasodilatation by restoration of the contractility to arterioles. So the management, this is the standard textbook approach. There are certain variations and there are proponents of other forms. This is an aggressive rehydration, 1.5 liters per hour to imperative to prevent azotemia. One strategy is to give 500 ml per hour of normal saline, alternated every hour with 500 ml of dextrose, with 50 millimoles of soda bicarb for each subsequent 2 to 3 liter of solution. And the target is to achieve a urinary output of 200 ml per hour, which is much higher than what is expected in other cases of AKI. Keep the urine pH above 6.5 and a plasma pH of below 7.5. Urinary alkalization with bicarb again has a doubtful role. It is unproven, but again it is useful to reduce the uricosuric drugs. And so is the use of mannitol to promote diuresis, but most often mannitol is used in the later stages. Whenever you suspect any drug which is found to be which might have caused this condition, you stop it immediately and treat according to the underlying cause. Now, regarding the view of this fluid which have been used for the studies on the rhabdomyolysis, we have seen that there are certain studies which have compared the use of bicarbonate, mannitol and saline versus only saline. Bicarbonate, mannitol and saline has shown no improvement over saline alone in one large study and one small study. And in another study where lactated ringer has been used versus saline, it was seen that it reduced the decreased amount of soda bicarb and diuretics when LR was used. So more of these things have shown, the trend of those researchers have shown that probably ringer lactate may be better than normal saline when used together. No studies about the balanced salt solutions available. Prognosis depends upon the extent and clinical severity of the rhabdomyolysis. General survival rate after a rhabdomyolysis induced ARF is pretty high. Some require dialysis for a long period, and even after recovery, all suspected patients should be investigated for predisposing factors. There is one column of genetic myopathy, so this metabolic myopathy, because they can recur. So this is all about the first condition. Going to my second case, 60-year-old male presented with high fever, chills and severe pain at the base of neck. This was attributed to an initial abrasion on his upper back, which gradually progressed to severe pain and swelling over the next few days. The patient was a diabetic, obese, long-standing hypertensive, and on examination he was febrile, tachypneic, tachycardic and as well as hypertensive. There was a large area of wood-like induration which was extending from the back of the neck forward to the chin and again downward to the upper back. On investigations, the HB was somewhere around 11, WBC was high, bands were 10%, glucose was high, HbA1c was high, and this was the CT which showed extensive gas formation in the soft tissues, you can see here, and it was dissecting along the fascial planes. The soft tissue gas was tracking along the cervical fascia too, you can see, to the carotid sheath, and then gas was present in the right sternocleidomastoid. So what is the diagnosis? Necrotizing fasciitis, absolutely fine, great. So this is again one condition which is rare but life-threatening soft tissue infection which is characterized by rapidly spreading inflammation and subsequent necrosis. It is frequently accompanied by moderate to severe systemic toxicity and can be fatal without prompt recognition and aggressive surgical treatment. 4 to 10% of septic episodes are there in this are reported, as well as the case fatality rate varies from 1.3 to 7%, which is not that high, it seems so, but of course if I diagnosed early. Trauma is the most common identifiable etiology in these patients, and majority of them have a history of that, minor or major traumas. Sometimes complicated intra-abdominal infections or chest wall wounds can also produce this. If the patients had an initial osteomyelitis which is followed by necrotizing fasciitis, that has a substantial higher mortality. And one cause which is found in the textbooks, particularly in certain oriental countries, is the consumption of raw or undercooked seafood, sea fish, and also injury due to fish fins during swimmers. Thus, they have been implicated in causing necrotizing fasciitis, not in our country, of course. So this slide is a bit complicated, but it answers a lot of questions that you can have on this condition. As regarding the predisposing factors, you can see and these are the lower extremities, and all those factors in some way or the other, either trauma or hematogenous translocation and immunocompromised host. So over a period of time, they produce infection of the muscle fascia, which produces poor blood supply, and these are the clinical manifestations. And this progresses over the next 3 to 4 days, giving rise to the proliferation of bacteria and production of toxins, which produces again lot of changes. And this is again manifested with the rising in the WBC, fever, and fluid and protein shift from the cells into the capillaries. And when it progresses beyond 4 to 5 days, it produces the typical tissue ischemia, giving rise to the features of toxic TSS, organ failure, and often leading to amputation of the limbs when they involve the extremities or so. So how to diagnose? Again, you have a classical triad of local pain, swelling, and erythema. The infected sites will have tenderness, sclerosis, necrosis, or bulla. And often, even before that, when the patient comes with pain, this pain is out of proportion to the degree of injury. So the patient feels a lot more pain than what is expected from the amount or the injury. So with progression, again, there is hypotension and raised WBC, all those changes which I had showed in the previous slide. And of course, in the late phase, there will be symptoms of septic shock or MODS. So this is the scoring system. It is pronounced as RINEC, not as LINEC, LRINEC, and which includes these variables, CRP, WBC, hemoglobin, sodium, creatinine, and glucose. The maximum weightage is given to CRP of more than 150. CT or MRI or frozen section biopsy can be carried out in patients with equivocal clinical findings and a moderate or high risk of NF based on a score of greater than 5. So what is the management? Management, of course, your antibiotics have to be started immediately, and the antibiotic have to be chosen according to the infection type. These are the various types of the microbiological type based upon the pathogen, site of infection, and the comorbidities. Type 1, 2, 3, and 4, and it has to be kept in mind while choosing the antibiotics. And antibiotics should be continued up to 5 days after resolution of local signs and symptoms, because of the poor blood supply of those sites, the organisms and the toxins, they don't get cleared that easily. And in case of severe streptococcal infections, high dose of IVIG may help. But the mainstay of treatment, of course, remains the emergency surgical debridement, which can be debridement only, or it may be a combination of debridement with necrosectomy or fasciotomy. But whatever is done, it should be done as early as possible, because the patients who are displaying intense skin and color change tend to deteriorate fast, particularly on those day 3 to 4. Nutritional support is required from the first day, and whenever the surgeons are using some device, the use of vacuum assisted closing device is useful. As you can see, because when this vacuum device is used, then that absorbs the excess of exudates, reduces the edema, and draws the wound edges together so that the healing becomes better. So that's all about necrotizing fasciitis. My third case, 38-year-old male hospitalized for skull-base fracture with seizures. Immediately after administration of valproic acid, develops high-grade fever, sloughing of total epidermis, and the clinical appearance of a severe burn patient. So what is the diagnosis? So fine. So both Steven Johnson and 10, they are considered to be the two ends of the same spectrum, at one end being the Steven Johnson and the other end being the toxic epidermal necrolysis. But the commonality is that this is both are severe epidermolytic adverse cutaneous drug reactions, differing only by the extent of the skin detachment. So one thing we have to importantly differentiate these two conditions is from erythema multiforme, because erythema multiforme is primarily due to infection, whereas these two conditions are due to drugs. So the lesions have a slight difference, because here you get papules, here you get a macula. Here the involvement is usually limited to 3 joints, the trunk, perineum, and the limbs, extremities, whereas in case of SJS and 10, the involvement is atypical. And there is extensive epidermal necrolysis in SJS and 10, and there is an elevated mortality. Between SJS and 10, you have to understand that both involve the mucous membrane, but the body surface area involvement is less than 10% in SJS, and it is more than 30% in 10. Otherwise, in terms of erosions, Hyperkeratosis, neutropenia, there is neutropenia, of course, there is difference because the 10 patients have more neutropenia in comparison to SJS, but regarding the involvement of respiratory tract, liver and the heart, there is not much of difference. So these are the drugs which are most commonly implicated in causing SJS or TEN, and you can find many of them are commonly used among the anticonvulsants, antibiotics, antitubercular and NSAIDs. So prognostic parameters are important because the score 10 formula takes into account these variables: age more than 40, presence of malignancy, heart rate above 120, initial percentage of epidermal detachment of more than 10, blood urea nitrogen of more than 28, serum glucose more than 252, bicarb less than 20. And when you give the score, if the score is 1, that carries a miserably low mortality, whereas if the score is 5 or more, then carries an abysmally high mortality. So this scoring is of relevance, particularly in a sick patient. So in these patients, the management will essentially have initial assessment, prompt withdrawal of the drug, which is the suspended culprit, prompt referral if facilities are not there in that center, supportive treatment and investigations. Disease modifying therapy is something which has come up of late, but which has an important role to play in the later stages, of course, and prevention of recurrence. This is the algorithm for acute management. You can see this also answers most of the questions that can be asked. You have to rule out infection and biopsy to confirm the diagnosis and continue with the life-sustaining measures, and very important, do an ophthalmic evaluation every 24 hours because it can produce certain defects. And here also you see that during conservative management, the cornea management is important. And if there is an increased uptake on fluorescent stain, of course that is the task of the ophthalmologist, but you have to know, which is limited to the bulbar conjunctiva, and the defect is less than 1 centimeter, your conservative treatment can continue. But if it is more than 1 centimeter, again you need to dose contact lens, scleral lens, etc. required. And in some patients may also require amniotic membrane transplant, and they have a high rate of rejection if not done in time. Another important aspect of management is to see that during initial exam, is it within 4 days of the symptom onset? If it is yes, then systemic steroids, pulse steroids can be added to topical steroids. And if it is no, then probably they don't have much of value. So you can only add topical steroids alone. So there has been lot of research on the use of steroids for TEN and SJS, and most of the time it has been seen that the certainty of evidence on the grade on mortality and hospital stay has been very low with the use of steroids. On the adverse effects, of course, the results have been, so the certainty of evidence is moderate. So we will have to take with a pinch of salt all the good things that are told about steroids, because the results do not show always equivocal findings. So the importance of supportive care is is of considerable worth in patients with TEN, because you have to see that the environmental temperature is maintained to prevent hypercatabolic state, monitoring of all those parameters to watch for the progression to complications like DIC, sepsis, PERDS or MODS, and prevention of infection by all these maneuvers to reduce the chance of sepsis. So what are the indications of using antibiotics in patients with SJS or TEN? Of course, either very high bacterial count from a single strain bacteria, either from the skin or urine, sudden hypothermia in a relatively stable patient, confused mental state, anxiety. So all this point towards sepsis and symptoms of infection pertinent to any particular system, which may be respiratory system or urosepsis. As I have already told, oral and ophthalmic care is very important, of which the daily examination by an ophthalmologist is important. Mouth and lip care is important too. If there are adhesions which are forming in the eyes, in the conjunctiva, they should be cautiously removed. And as I had told of amniotic fluid membranes are useful. How to prevent infections in such patients? Barrier nursing, regular hand hygiene, avoiding unnecessary insertions of catheters and lines, monitoring for the focus of sepsis, environmental controls for dependency units, and activate sepsis protocol early. So from these three cases, my take-home message to you would be that skin and soft tissue ailments have a variety of presentations, and these presentations are often the intensivists are not familiar with because they don't present too often. It is a complex and there is a need for a multidisciplinary team approach, but it is important to remember that they can be very severe if missed early, and intensivists should be familiar with the spectrum of clinical presentations and their management. And besides treating the primary cause, one should pay strict attention to fluid and electrolyte balance, restoration of the temperature or normothermia, wound care, pain control, nutrition, and prevention of infection. Thank you. If any question I can take. I think I'm on time.
Yeah, it's on time.